to the monthly patient education forum of the Arthritis Support Network of London. Thank you for joining us. My name is Dr. Guy Dabrera. I am a retired consultant rheumatologist, and today we have the pleasure of the company of Dr. Thushani Wickremaratna, who is a senior consultant rheumatologist and a general physician at Queen's Hospital. Thushani has a very busy work commitment, and we are extremely grateful to her for agreeing to talk to us today. Thushani trained in rheumatology in the Southeast London rotation and worked in quite a few teaching hospitals, including St. Thomas's Hospital, London. She has been at Queen's Hospital now for a decade. Seems to me like it was a longer time, but it is 10 years. And she is the lead rheumatologist for osteoporosis, which I know is a subject that's very close to her heart, and she specializes in it. So, Thushani, a warm welcome to you. And with that, without any further ado, I would like to ask you to explain to us in simple terms what uh, what is osteoporosis?
Okay, thank you very much, Guy. Thank you for your kind introduction. Um, and thank you very much indeed for inviting me to do your educational forum. You have been talking about this forum, the patient group, with me many, many times. And it's a good opportunity for me to meet your members. So hi to you all again.
Hi.
So in terms of osteoporosis, if I start by describing the term what osteoporosis means. Osteo means bone, porosis means holes. So there are lots of holes in the bone. So that is by definition um, the term of osteoporosis. Now, as you know, the bone is a living organ. It is hard, it is solid, but it is a living organ. And it has an outer structure and an inside structure, which looks like a sponge. But what happens with this disease is that these holes, the sponge, become larger and the holes become larger and resulting in a thin bone. So when the bone is thin, it can fracture, or it can, slight trauma can break the bone. So that results in a fracture or breaking the bone. So it is a very, very common disease, more common in the females than in males. In males, it was very underdiagnosed. But now with increasing awareness, it's gaining more prominence. So there are two main contributors or two main factors. One is age. With increasing age and increasing aging population expected in the next decade or so, you will find that there is increasing number of people with osteoporosis. And the other is the female sex. Unfortunately, the females tend to get it more commoner and therefore are more prone for the osteoporosis. So why this osteoporosis important is because of the fracture. The fractures that are more common are the back or the spine fractures, or the wrist, or the hip. So what we try to aim is to prevent a hip fracture, because the hip fractures, if you get a hip fracture, 1 in 4 will die. 50% of them will lose their independence, and there will be some form of disability. only about 20% who will regain their pre-fracture status in the long term. So that is the important thing. And one
Yes.
of the
So
other
Tushar,
important thing,
let me come
yeah,
in
sorry.
there. So it is a extremely important condition because it predisposes to major fractures, and obviously that fracture then can endanger life. So how would someone know if they had osteoporosis?
Yes, so that's very good condition. That is what I was going to come into.
Thank you.
The osteoporosis is a silent disease. So you will not know unless you get a fracture resulting in pain. So when you say fractures, these are specific types of fractures because remember I mentioned about the hole in the bones where the bone become weak. They become weak and therefore a slightest trauma can break the bone resulting in a fracture. And these fractures are known as fragility fractures. And classically, the trauma or the injury is less than the height of the individual person. So until you get a fracture and you suffer the pain, which is the consequence, you will not know. So awareness of this condition as we increase, as the age increases, the awareness is also very important. The patient education, like your groups like yourselves, are a vital factor.
Okay, Tushani. So at that point, can I ask you what are the risk factors, or what are the sort of, in other way, what are the predisposing causes for osteoporosis, especially because it is silent, and quite a number of us, as we reach our seventh, eighth decade, could have osteoporosis because it's a silent condition. So, which one of us is more prone to get this condition? And if you could help us out with some of the risk factors and the predisposing causes, please.
Yeah, so sure. There are risk factors, obviously, the not modifiable one, your sex, the female sex, the genes that you carry, the family history. If your parents had osteoporotic or hip fracture, um, those are features which are not modifiable. But more importantly, modifiable or the factors that you can change, these are important. It's always it's one thing that we got to remember is that it's never too late to do something to protect your bone health. It's very important. So what are these modifiable factors? Smoking, alcohol, certain diseases can be prone, postmenopausal osteoporosis in women. And then we're talking about, sorry, what was I going to say? A history of previous fracture, that these are again risk factors. Then certain diseases, the well-known diseases can be
Thyroid problems.
like thyroid, gland in the neck, the thyroid, the parathyroid, if you have overactive of this, or if you have celiac disease, inflammatory bowel disease, like Crohn's and things like that. So those are the risk factors, which unfortunately we don't have much control about. Medications. The medications are more likely are the steroids. Steroids is quite commonly used. Particularly, if you have asthma, COPD, you're given steroids, and high dose of steroids is a well-known risk factor. Anti-epileptic medications, breast cancer treatment drugs. sorry, I forgot another major important factor is diseases like rheumatoid arthritis. I'm supposed to be mentioning that. Uh, this is a patient arthritis group. So rheumatoid arthritis, autoimmune diseases. So those are very important risk factors.
Tanya, can I ask
and
you?
also, one of the other important, sorry, Guy, I missed something.
No, I would let you go on to that important cause and then fire my question. So go ahead.
Yeah. Now, what I was other thing is, this is one of the other conditions. Interestingly, if you have a higher BMI, you are relatively protected. Because if you have low BMI, if you are thin and slim, you don't have a more of a fat pad, and then the risk of falls and there's a risk of fracture. So if you have a good fat pad to protect yourself, then the risk of fracture also becomes less. So, so that is a protective. Increased BMI is a protection.
So could I take you back to genetics
Mm-hmm.
and ask about the family history? Because you did allude to that. And in terms of the risk, is it more a maternal osteoporosis or is it from the father's side?
It is actually considered as a first degree relative, particularly parental. And obviously, the females are at high risk.
Yes.
So if your mother had a fall and a hip fracture, then the risk is much, much higher. And if you have sustained a fracture in the back spine or in the arm, then you are at a higher risk of a second fracture. So, and the other important things I would like to mention is, you asked me, Guy, about how would you, this is a silent disease, how would you diagnose or how would you detect it? So back pain is an important feature because back pain can indicate the fracture in the spine. And over the years, you will realize that you are becoming more shorter and more stooped. So these are the indicators. I mean, it is well known aspect that back pain is considered as, oh, it's a normal aging process. But it is also at the same time important to know, because trivial movement, bending down to pick up something, coughing vigorously, could result in a break of this bones, the spine bones, and causing a fracture. These are fragility fractures. So again, coming back to these fragility fractures, if you have a 90-year-old gentleman, this is an example I quote quite frequently. If you have a 90-year-old gentleman who goes up the roof and falls down and break the leg, that is not an osteoporotic fracture, because it has to be a fall of less than the height. And if the same gentleman tripped, fall on an outstretched hand and break the wrist, that will be an osteoporotic fracture, because it's a trip and a fall, low trauma.
Thank you for clarifying that, Thushani. Can you also tell us the how immobility contributes to loss of bone and osteoporosis?
Yes. So if you are as you grow old, you are at high risk of falls. So falls prevention, identifying what are these falls risk. It may be things kept in the corridor on the driveway, or a muddy pathway, a slip, or footwear. So it's important to identify this and address this, because these are high risk for increasing risk of a fall and
Most of
sustaining
the
of a.
falls happen at home. that correct?
Exactly. So that's what that's what, you can have items in the corridor, in the stairways, you can just only trip, fall, and break a bone.
Right. Thank you for that, Thushani. So, if say one of us identifies ourselves from what you said as having a high risk of probably having osteoporosis, what should one do?
I think it is very important that you don't wait until you fracture. Um, this entire group is, I believe, is well computer literate. So, by all means, do go on this Royal Osteoporosis Society, which is patient focused, a society that addressed the patients, the healthcare professionals on the osteoporosis. It gives lots of information. It
Sorry, is
used to
it
be
the
known as
same?
National Osteoporosis Society in the
Yes.
past, but since recently it's changed to Royal Osteoporosis Society. And that gives lots of information. I mean, almost all of the patients, I tell them, by all means, do go into it. And one of the common things that they ask is, if I have osteoporosis, am I eligible for benefits? And sadly, the answer is no, you are not eligible for benefit for the sake of having osteoporosis. But there are lots of information there about the treatment, the diagnosis. So have a look at this website. The colleagues are very well computer literate. So have a look.
What would you say, Thushani, is the gold standard test to diagnose somebody with osteoporosis?
We consider the DEXA scan. I'm sure you must be aware of DEXA scan. Have you heard of DEXAs? It's a density. It tests the bone mineral density. So there's a kind of strict criteria. The WHO classification is based on a score which we called in adults at T score, which is equivalent to about a 30-year-old young woman. So any score a T score less than minus 2.5, by definition, is an osteoporosis. And what is measured is the spine and the hip. And it's important that you look at the neck of the hip. It is a very simple test. It doesn't involve any radiation. It doesn't involve any, it doesn't involve any cannulation, drugs, intervention, things like that. You go, you are given a form, you lie down on a couch and a X-ray machine goes over and it concentrates on the spine and the hip and it gives a score. So the T-score, if you have a T-score of less than 2.5 and a fracture, then by definition, this is considered as established osteoporosis. If you have anything above -1, that's a normal BMT. When you are interpreting this as healthcare professionals, we have to be careful. What it assesses is the calcium. So if you have a lot of arthritis in the back, osteoarthritis, which is very much different to osteoporosis. They are two entirely different conditions. If you have osteoarthritis, you have calcium deposited, and that calcium can be accounted in the DEXA machine, which can give a spuriously incorrect value. So you've got to be a bit aware of that. So somewhere in between these two categories, -1 and -2.5, is by definition what we call osteopenia. Again, it means it may predispose to osteoporosis. If you don't look after your bones, it definitely will. If you continue to drink, if you continue to smoke, it definitely will. And
So,
that is the root of
can I ask,
osteopenia.
Thushani, then, you alluded to the scores which would diagnose somebody with osteoporosis, but you and I are aware that there are these patients who do not have normal bone, and neither do they have osteoporosis. And the intermediate condition, could you say a few words about that?
Do you mean osteopenia?
Yes.
Yes. So osteopenia is by definition, it's a DEXA diagnosis where you get that that scoring value. So if a patient who has osteopenia continues on a jolly life, then they
Without
are
treatment,
bound
you
to
mean?
get, yes, without, we'll come into that treatment because the treatment depends on whether have you had a fracture, have you had risk factors, have you addressed those risk factors, and then what is your risk. As we assess as healthcare professionals, we have different tools.
So
Sorry,
osteoporosis
the audience
and
is very quiet. Does it mean that you are
no, they
all
are listening.
with
There,
me or?
I can assure you that they are listening intently, and at the end of this, they will have questions to ask. So we'll give them a chance to
Sure.
ask them questions. But I want to ask you, so osteopenia and then osteoporosis, how would I get a DEXA scan, I or one of the participants or their families or anyone else uh, get a DEXA scan here in the UK? What's the best way? Is the GP or private provider or in the community?
Yes. So approaching the GP is the best way. We at Queen's Hospital, unfortunately, I don't do private work, so I really don't know the private sector. I don't know much about that to comment on how to get a DEXA. But I'm talking about the NHS, if that's all right.
Please, yes.
GP is the main port of referral. Um, we at Queen's, we have given clear guidelines to the GPs on who to screen. Everyone above 50 who have these risk factors, particularly if they have a fracture, please arrange a DEXA scan. And then again, after the DEXA scan, we have also given guidance on how to follow or how to treat, etc. But we have a dedicated fracture liaison service, which is very important in the terms of long-term prevention of a secondary fracture, more importantly of hip fracture. So the fracture liaison service is aimed to identify, investigate, which means doing arranging DEXA scans, patient education, and starting treatments. So all of those components are done by the FLS. We have developed a system with the radiology. If they routinely detect fracture in the spine, so when we say routinely detecting fracture means we look at the spine vertebra, and if they are compressed, if they are small, we assume that they have had a fracture. All these patients are invariably, they might have had a fracture for they might have had an X-ray of the spine for a very irrelevant reason. But we have a system where critically referred to us in the FLS, and we take on board. So every month we get a list of patients who have had X-rays of their back, and we assume they have had a fracture. So these patients are again individually investigated and assessed. All patients who have had a fragility fracture or a low trauma fracture who come to the A&E or trauma and orthopedic fracture clinics, they are invariably referred to us in the FLS.
So, Thsuhani, can I stop you there and ask you? So, all patients whose X-rays confirm a fracture would have screening for osteoporosis. Is that right?
Yes, all patients who have had spinal x-rays, and who the radiographers suspect there's a fracture, they are referred automatically to us.
Excellent. So in terms of having the condition diagnosed, there seems to be a good pathway, and people in the community can of course go to their GP and ask for a DEXA scan. So once it is diagnosed, what are the treatment options?
In terms of the treatment options, nothing can be emphasized more in addressing the modifiable factors, the alcohol, smoking, diet, exercise, calcium, vitamin D. Those have to be addressed because the treatment is not going to work if the above is not addressed. So that that portion plays a very important role. Next comes identifying, is there a cause for this osteoporosis? In other words, is there a secondary cause? So we do set of bloods, which...
I'll ask, can I call you back? I'm in a small meeting. Excellent, thank you. Thank you. Sorry, Thushani.
That's all right.
So,
That's
were you talking about the modifiable causes?
yes, addressing them, and then you have to look for, is there a risk factor for the osteoporosis? So
Yes.
so therefore we do a set of screening bloods. There's two purposes of this screening bloods. One is to identify, is there a risk factor? For example, in a male, we do a PSA in every male patient because the prostate cancer can be detected by an osteoporotic fracture. We do the full blood count, the kidney, the renal, kidney function, liver function. The kidney function is important because you have to, the patients have to have a satisfactory kidney functions to start
Indeed.
on the treatment, whether it's oral or intravenous, by a drip, or whether they are suitable for any other treatment if their renal function is not great. So we check their thyroid status. We do a celiac screen because there is a certain percentage who you incidentally detect that they are celiacs. Then you
Can
do the
we say
electrophoresis
in
and
simple
myelo.
terms what celiac disease is?
Gluten sensitivity.
Okay. So in terms of looking at causes that can be modified, underlying diseases, we do the screening, and that's traditionally done. And if we find the condition that can be treated, it's so well and good. But otherwise, you're left with somebody who's got osteoporosis or osteopenia. And uh, I know the majority of patients would be in the old and wiser group, especially females. But osteoporosis, like you said, does also occur in males. And also, it can rarely occur even in the young age groups, can't it? Can you tell us a
Yes.
little bit about young onset osteoporosis?
Yes. So, I mean, you can get osteoporosis in children, but I'm not an expert to talk about osteoporosis in children. So if you're talking about young people, one of the commonest factors are the dietary. Anorexia is a very common. If they had menopause early, premature menopause, either because of hysterectomy in their early 40s. So those are the common group. When it comes to children, it's entirely different, and I'm not, experienced, or I'm not an expert in terms of talking about children, but in children there is osteoporosis. There are hereditary diseases you have to think about, and the DEXA scan is based on a very different scoring, which
Yeah.
is age
But it's
appropriately
much less
calculated.
common, isn't it? It's much less common.
It is less common, and in a child you have to look for a hereditary cause.
All right. So I think we've covered quite a bit. Can you tell us a bit about what drug treatment is available currently on
Yes.
the NHS?
So coming back to the my original explanation about this bone, the sponge, the cortical bone. In the bone there are two important cells. One type is the type that builds the bone, which are called osteoblast. And there's another type which eats up the bone. They're called osteoclast. So they act in harmony and maintain the bone health. So if the bone forming cells are less, then your bone is thin, you can fracture. So if the bone eating cells tend to eat up the bone more, then again your bone becomes thin and a risk of fracture. So the treatment is mainly the most common. The first treatment is where you stop the bone eating, the osteoclastic or anti-resorptive as a medical term. So that's the first line of treatment. I'm talking now about specific treatment, having addressed the modifiable factors of lifestyle changes, the alcohol, the exercise, calcium, vitamin D, etc. So this is specific treatment. So there's another treatment which builds up the bone. They are the injection. And there is the other treatment which acts on both the system, dual active. So that comes the strontium and the most recently approved, but not yet approved in England and Wales, the injection treatment.
Good. So there are several options for treatment, and there are drugs that you can pick and choose. And of course,
Yes,
there are these certain individuals who do not tolerate certain drugs, and also compliance can be an issue. Um, how many patients keep taking the medication, say after the end of 1 year, and how long ideally should the treatment continue?
yes. So when you're talking about the specific treatment, one of the first line of treatment is stopping those eating the bone, the osteoclastic treatment, which are called bisphosphonates. So there are various types of bisphosphonate drugs. The tablets that you can take orally, which are given weekly, some are given monthly, and then you can have treatment which can be given through a drip, which can be given 3 monthly or every year as a drip into the vein. So that's the first line of treatment. So these tablets, which are called in a group as bisphosphonates, they have to be taken quite specifically. It's very specific. One of the few medications which needs very specific instruction on how to take. They have to be taken on an empty stomach. You have to stand upright or sit, not lie down, for at least 30 minutes. And it has to be taken with water, not with milk. So that is very, very specific. So this can be a bit of a nuisance.
And taken in the morning.
If it is weekly, first thing in the morning, empty stomach, seated upright. So this is because these tablets, they cause lots of tummy irritation.
Yeah.
So you can get sickness, you can get, very irritated stomach. So that is why the compliance is not all good. And if you're taking that once a month tablet, you have to be upright for an hour, which is
Yes.
could be a long time, isn't it?
But upright can
But
mean walking or
yes,
even taking
yes,
a
not lying
shower,
down,
if you like, isn't it?
not lying
Right.
down.
As
That's
long as you're
that's
not sitting
the
down.
yeah, not lying down
So
because
along
that
with
irritates.
tablets, how important is it, along with the once a week or the once a month tablet, how important is it to take a calcium and vitamin D supplement?
Yes. So remember, I said that these stop the eating of the bone, the osteoclast, as we call it. So for this to work, it's important that there is the adequate supply of the calcium and vitamin D. So these medications will work if there is a concurrent supplementation with vitamin D and calcium. Now, certain patients are not suitable for these tablets. If you have severe gastritis, if you have inflammatory bowel, if you had any gastric surgeries, if you are prone for ulcers and bleeding, this tablet treatment may not be the best treatment, in which case we advocate the once a year medication, which is the same class, bisphosphonate group, and they are called zoledronate. And it's given once a year, which is very convenient. Come to the hospital, it's have it within 15, 20 minutes, and that's it for the whole year.
And that's given
So
intravenously.
it's given through, you put a small cannula into your veins and give the drug. One of the important things is to have these drugs, your kidney function should be pretty good. So that is why we check for their kidney function before they have this drip. So that is very suitable if you can't tolerate. And also the advantage is that the compliance. There is evidence that in our frail elderly group of nursing home residents or above 75, even one dose would be suffice rather than giving the 3 doses, which is the standard. If you're given the tablets, the duration is 5 years. We don't usually encourage more than 5 years because it can cause an issue. Sorry, my computer says internet connection is poor. Can you see and hear me?
Yes.
Yeah, we can see you and we can hear you. You can speak slightly louder, that will be fine.
Okay. Oh, right. Okay.
So can I ask you, if somebody cannot take the bisphosphonates, and also after 5 years, are there other drugs that these patients could have?
Yes. So we have given clear instructions to the GPs, to our primary care colleagues, on what to do if the patient can't tolerate the tablets, if the patient is not suitable for tablets, what options are available. If your kidney function is not that great, there is a medication that can be given into the skin every 6 months. That is called Denisumab.
Yeah.
It's given every 6 months for a period of 3 years. Obviously, every patient is an individual we assess at the end of the course of the treatment. Some, after the 3 years, we would give a zoledronate to what we call a sealing of the bone. Some we may continue with the Denisumab. So it's an individual assessment based on whether they have had any fractures, how tolerant are they to treatment. and their DEXA report.
What are the side effects of taking biphosphates, something like alendronic acid or residronate, for more than 5 years?
So one of the commonest side effects are there any?
Are there any, is it?
Sorry, I didn't.
Is it detrimental if you take them for?
Sorry?
What are the side effects, or how detrimental is it if you take it for more than 5 years, say 10 years?
Right, okay. So the recommended period is 5 years. We did a audit with a couple of GP surgeries because there are lots of GPs who are very interested in the osteoporosis. So we did an audit and we found that there were quite a few patients who were taking it beyond 5 years. Some were 10, some were 20.
Yeah.
But
yeah.
No major side effects were noted. But then again, you have to assess whether were they compliant, were they taking it weekly. So, there are other things that you had to look into. But one of the commonest side effects is the sickness, the nausea, the gastritis symptoms. So we have to, first what we do is we assess whether the patient takes the tablets in the correct way. And if they are really intolerant, then the intravenous, the drip is the best option. So after 5 years, it is important to assess by a DEXA scan to see, is there any progression? Is there any improvement? Has the patient, more importantly, sustained a fracture in between this period? And if there was a fracture, why did the patient fracture? Was it because of lack of compliance, or was it because the BMD or bone mineral density has worsened? Then we have to reassess again as an individual person. The rare side effects, Diane, I think, asked about the rare side effects or the side effects or the detrimental effect if you take it more than 5 years. There have been episodes reported as a jaw, part of the jaw becoming necrotic or becoming weak. And that is a significant. Rare. It is very rare. And one of the ways you can avoid it is maintaining good oral hygiene. So it is important to maintain a good oral hygiene, regular teeth brushing, things like that. The dentist, they usually tend to refer to the hospital if you are on the drip treatment for this bisphosphonate, purely because they don't like doing grilling around the jaw area because of this risk, but it is very rare. Another rare side effects is the risk of a fracture, as we call atypical fractures, particularly around the hip area. So if someone who is been on bisphosphonate complains of a thigh pain or a pelvic pain, we do tend to look at it seriously and try to investigate. When I talk about investigation, it's usually an MRI scan we do to see that there is no fine cracks or atypical fractures, which again is very rare. Both these side effects, unfortunately, are associated with this, the anti-resorptive or the osteoclastic treatment.
But to put it in context, Thushani, these drugs
there is
stood the test of time,
hormone replacement therapy or HRT. Sorry.
No, just saying that these bisphosphonates have stood the test of time.
Computers.
And they worked very well in the treatment of osteoporosis, apart from a few people who react adversely or are not suitable for the treatment. And so they've been in existence now for about 3 decades.
Sorry, the line was very interrupted.
So we have been successfully using the bisphosphonates
Charger.
for over 2 decades now, haven't we?
Oh, yes, yes,
Yes.
yes. So, I mean, these side effects are becoming increasingly being more aware, I would say. Could you give me 2 minutes for me to plug this to see if it is a
That's okay. Yeah.
adequately charged computer, but there's lots of interruption.
Yeah, go ahead. I think that's fine for now, Dr. Wickremaratna. Thank you. Yeah, we'll perhaps I could hand over to Dr. Dabrera to talk through that. That's interesting information. I wish I'd known that when my mum was ill about 15 years ago, because sounds like she had all the symptoms that you're discussing there, but we didn't know that at the time. So, yeah, so Dr. Dabrera, is there anything you'd like to add to that?
Yes. So, Thushani, thank you for all that. Is your computer back to normal?
Yes, yes. Well, yeah,
Okay.
the interruptions,
continue
yes. Yeah.
Can I possibly ask, Doctor? First of all, you stated about lifestyle modification. It reminds me of a quote from an oncologist called Siddhartha Mukherjee. He said that genetics loads a gun and lifestyle pulls a trigger in relation to cancer. So basically, my question is that why is there such a variation? My late father had a fall. Unfortunately, he passed away a few months ago. But the question I have is related to the older population. Is that when you have a fall and you know, why is it there's such a high rate of? You touched on this at the beginning of your presentation. Why is there such a high rate of death amongst people who have falls in the elderly population? Why is it can it be such a fatal episode in their lives? And secondly, I noticed with my late father, there's such a poor support service outside of the hospital. And there can be huge variations in terms of the way GPs support patients, because I'm a patient chair for the PPG in my surgery. And the variation I hear from different patients of different surgeries, that the support they can get can be so varied. And given it's such an important thing to primary care to ensure that the support is given at the right time, what do you feel can be done more from a primary care perspective to actually lessen the death rate and to have more of a falls prevention service based guidance for people who are more prone to having these episodes? From your point of view, what do you feel is the most important thing?
Yeah, I think these are very, very relevant questions and quite common, sadly. In terms of addressing your first question, sorry, I didn't catch your name.
Deepak.
Deepak. So Deepak, addressing your first question, why is these patients with falls are at a higher risk of death? Because when you have a fall and if you have a fracture, your mobility is impacted. You are bedridden or your mobility is severe. So if you become immobile, you are at a high risk of infections. Urine infections, chest infections, so the risk of infection is high. So higher the rate of infections, you are more prone to succumb to it. Secondly, when you are immobile, you are at high risk of getting clots. So clots in the legs, which can extend to lung, clots in the lungs. Then most of these patients also have other risk factors. They may be hypertensive, they may be diabetic, so they are at high risk of stroke and heart attacks. So all these, what we call as comorbidities, come into play. They become more active. And sadly, those are the major contributors for the death. I touched briefly on this. The importance of the osteoporosis is preventing a hip fracture. an independent lady around the age of 80 who unfortunately sustained a hip fracture loses the independence totally, become dependent on others for daily activities. So that increases her vulnerability, not in terms of the physical difficulty, but also of the social isolation and all other associated factors. So there is a huge impact on that. Secondly, what have we done at Queen's or BHRUT in terms of supporting our colleagues in the primary care? So we have had clear pathways of how the primary care should A, identify more patients, B, how to treat these patients to prevent any falls, prevent any fractures. So the GP awareness is also important, and it is also something we have addressed. Secondly, is there are dedicated falls clinic, where if you identify patients who are at high risk of falls, they are given one-to-one advice, assessment on how to prevent falls. There is this occupational health, the physiotherapist who will visit the individual homes and identify which can be triggering factors to falls, identify them and address them. There needs to be a lot to be done. There needs to be a lot of support. So our care of elderly is also quite active in terms of this. When patients are admitted, they look into all aspects. They look into not only the risk of falls, falls prevention, fracture preventions, etc., but they all look into the other things like the dietary implication, the nutritional support, etc., things like that.
Sorry, can I ask you and confirm that the treatment for osteoporosis is getting better year after year, and more recently there has been the advent of newer drugs. And although the main target of treating osteoporosis is to prevent the bone structure getting any weaker or softer, now there are drugs that can also treat the osteoporosis, prevent the bone from getting weaker, but also try and make it stronger. Is that the way the treatment of osteoporosis is going? Eventually, that will be the target, to try to make the bone stronger, because that will be a real incentive for our patients with osteoporosis to stay on the treatment, especially if they know that their bones are going to get stronger rather than just being prevented from getting weaker.
Yeah, that is important in terms of strengthening the bones, improving the bone formative medications. But with that should run parallel the other ways of how you can look after your bone health in terms of exercising, daily exercise. It is recommended that at least some form of exercise is better than nothing. So exercise at least 2 hours per week, which if you can increase the intensity, that is better. The brisk exercises, walking, jogging, weight bearing, muscle strengthening exercises, even doing your own shopping, carrying the heavy bags home. That itself is a muscle and bone strengthening exercise. Cycling, swimming. So that is important. The daily calcium, vitamin D intake. When it comes to calcium, a good dietary intake. So calcium comes mainly from dairy products, fortified cereals, things like that. And it is thought that if you have a good dietary intake, you will get an adequate daily calcium, which is around 700 milligrams a day. Should be adequate, but supplementation with calcium and vitamin D would be helpful. There are certain cutoffs. You don't recommend more than 1,500 calcium intake daily, because high calcium intake can cause other problems like commonly the stomach pains, stones, etc., etc. So you wouldn't rather not. And other thing is the vitamin D. So vitamin D is commonly a source from sun, and in winter we have no sun, and in COVID we have no sun, nothing at all, even during summer, because we are stuck in. So particularly during the winter period, it is important additional vitamins supplementation. So 400 units of vitamin D is what is the normal. So what is the recommended daily intake? And it is important during the period of October to March, roughly covering the winter period, that extra vitamin D is taken. Other times, the exposure to sun is the best source. Coming into that, I think I briefly forgot to mention about, in terms of the high risk, I mentioned about females, and I mentioned about the non-modifiable risk. So the race is also a risk factor. So it is considered that Asians and Caucasians are at a high risk in comparison to the colleagues of Afro-Caribbean.
Okay. So Thushani, we've been going on for about 1 hour, and I therefore now would like to take this opportunity to ask anyone else in the audience who wants to ask a burning question, and to keep it short, please.
Would osteoporosis prevent you from having knee replacements or hip replacement?
No, no. I briefly touched on this. Osteoporosis is a disease of the bone. Osteo means bone, porosis means holes. So it is a disease of the bone. Osteoarthritis, which is the most common reason for hip knee replacements, is a disease of the joint. The joint is made of the bones and the shock absorber, the cartilage. So this cartilage acts as the shock absorber, the lever. So unfortunately, with age, you find this shock absorber wearing out, and the bone on bone grinds on each other. And that is why causing the pain and needing the replacement. So they are two entirely different diseases.
No, what I'm saying is, if they find when they x-ray you, you've got osteoporosis, will they not do the replacement, or will they?
Sorry, could you kind of clarify a bit?
Can I reword it? I think what
Yes.
David is asking is, in the presence of a background osteoporosis, would a knee replacement be contraindicated?
No, not at all. Not at all. That is why I'm saying that they are two entirely different diseases. So just if you have osteoporosis,
Doesn't stop you. Yeah.
it doesn't stop you having a replacement. And it doesn't, unless you have, a person with osteoporosis can break the hip, and that hip can be replaced, which is the treatment. Am I making myself clear?
Yes. I think so. I think in an emergency situation, Thushani, what you said is absolutely right. You go in the hip fracture, which is secondary to osteoporosis, and you have a replacement to treat that condition. But I think what David is alluding to is probably when it comes to elective knee replacement, then may be that there are some orthopedic surgeons who, in the presence of quite severe osteoporosis, when the bone is very soft, might say, well, I might put it off for 3 months to allow you time to have some treatment for your extremely thin bones, because the prosthesis might not hold onto the very soft banana-like bone that you've got, and unfortunately you haven't had treatment. So such instances are rare, but on occasion, maybe the orthopedic surgeon wanted to do that because therefore he gives the prosthesis and the knee replacement a longer lifespan as the bones are stronger. Although it
Yeah,
could take much longer than 3 months for the bones to get stronger.
yeah. Yeah, I mean, those instances are very rare, very rare. What I would say is more commonly what is seen is when patients are on bisphosphonate, particularly a long term, that again concerns the concerns the orthopedic surgeons regarding the healing process. So they are more concerned because of the longer duration of the bisphosphonate, that the bone itself is remodeled abnormally, if I'm using the appropriate correct word. So therefore the healing is delayed, and therefore it's best to stop the bisphosphonate for a while, allow the bone to heal on its own, and then do the replacement to give that strength. Because of the risk of atypical fracture and the delay in healing with bisphosphonate.
Exactly. Yeah.
Okay, David, did it answer your question to a certain extent? Okay. Anybody else?
Yeah, can I ask a question about diet? If you're a vegan, I'm a vegan, and you're saying that calcium primarily dietary-wise comes through dairy products, would that can you get calcium in any other form? Is it in any other food?
You can get calcium in particularly green leafy vegetables. Kale, spinach are good sources of calcium. You can get fortified, cereal products added extra calcium, or you could take calcium tablets, vegan calcium tablets on its own. So what we
Don't forget
usually...
the nuts, nuts.
Yes, so sorry, yes, yeah. And pulses.
Things like lentils, you mean?
Yes, lentils.
Yeah. Oh, that's good, because I eat loads of them. Okay. Thank you.
So if there are no more questions, then it is my duty to extend our gratitude on behalf of the Arthritis Support Network to you, Dr. Thushani Wickremaratna, for giving up your valuable time and for enlightening us and updating us on osteoporosis. It's been a very, very good discussion. I think we learned a lot from it. So thank you very much, and we hope you will join us again for a further session on another subject in due course. Thank you.
Thank you. Thank you very much for inviting me.
So, Dr. Wickremaratna, that's great. Thank you very much.
Thank you. Thank you. Have a good evening.
Bye-bye now.
Stay safe. Good evening.
Bye-bye.